And it's a pleasure to introduce Karen Canfell, who many of you will know because she did a PhD in the Cancer Epidemiology Unit. I hate to say, but it was something like 20 years ago. She worked on cervical cancer then, and she has just gone from strength to strength in that field, as you'll see, and I'll tell you about that in a moment. She's now head of the director of the Cancer Research Division in the New South Wales Cancer Council. She has quite a large group of scientists working with her who work on all sorts of aspects of cancer epidemiology, cancer control, and have been key in the development of the 45 and up cohort study, prospective study of 250,000, a quarter of a million people in Australia. It's the biggest cohort study in Australia. But Karen's work herself has been largely, her own personal work has been largely on cervical, well, on cancer screening and modelling and control. She's going to be talking to us today on the road to cervical cancer elimination. What will it involve and how long will it take? And she has really one of the foremost people in the field in this field. She's worked as a key person in the WHO cervical cancer elimination program, and works closely with the International Agency for Research on Cancer on that. So I'll hand over to Karen for the moment. It's now Wednesday there after midnight in Australia, so she's giving our 9th of March talk on the 10th of March. So thanks very much, Karen. Good.
Thank you so much, Valerie, and thank you to all for the invitation to speak today. I'm really delighted and honoured to be here, and I just wanted to acknowledge all my friends at Oxford to say hello 2 days after International Women's Day. It's a real pleasure to be here to talk about the road to cervical cancer elimination. So let's set the scene. This is Globocan 2018, the results for the most common causes of cancer death in women, the estimated most common cause of cancer death by country. And you can see from this that breast cancer was estimated to be the most common cause of death in 103 countries, but cervical cancer, the most common cause of cancer death in 42 countries, followed then by lung and colorectal. And I guess the key point here being that you can see this enormous disparity. It's in fact the poorest countries in the world that have the highest burden of cervical cancer. There are globally, or there were estimated to be in 2018, 570,000 new cases diagnosed and 311,000 deaths from cervical cancer that year. And you can see this, this picture, this dichotomous picture, which really reflects that cervical cancer is essentially a disease of inequity, and it really reflects lack of access to services for cervical cancer prevention and control in the world's poorest countries. And yet, effective tools for cervical cancer prevention and control are available. And I just wanted to take a moment to explain why this is so. It's so for a very obvious reason, because we clearly understand the causal role of HPV, which is underpinning almost all, virtually all cervical cancers. And essentially we have, as a community, a global cancer control community, we have capitalised on this understanding. And here I've just wanted to highlight, I think, 3 of the main contributors that have inspired me along in my journey in terms of contributing to this understanding. And just really to acknowledge Valerie herself. One of the papers that inspired me as a PhD student was her sole-authored Lancet 1974 paper, which was an ecological analysis looking at the association between mortality for cervical cancer and patterns of STI infections and incidents in England and Wales and in Scotland. Also pictured there is Harold Zerhausen, who many of you will know, really first proposed that HPV underpinned cervical cancer, and with others really identified HPV 16 and 18, some of the key causal types in cervical cancers in the 1980s. And then thirdly, I wanted to point to the work of Mark Schiffman from NCI, who's really been the person that I think through the 90s and the 2000s clarified the natural history of HPV type-specific persistence and progression, and I really articulated the natural history of cervical cancer and showed how that played out at a population level. So this is really a depiction, a simplified articulation, if you will, of Schiffman's model, conceptual model of cervical cancer carcinogenesis. So you can see here this idea that you have a normal cervix. It can become infected by HPV, and in the pre-vaccine era, this was incredibly common. It often happened after sexual debut, and various estimates, in fact, put that lifetime risk of infection with HPV at around 80% in some cases. But it was really viral persistence and then progression that put a woman at risk of developing, firstly, precancer, which is in fact quite common in younger women. This is alternatively known as CIN2 and 3, cervical intraepithelial neoplasia, grades 2 or 3. The most serious of those being grade 3, CIN3. And then this potential to develop invasive cervical cancer, which we know from a unethical, unfortunate experiment, as it's called, that occurred in New Zealand starting in the 1960s, where women were not treated with CIN3. We know that the progression rate from CIN3 to invasive cervical cancer is of the order of 30% or so over 30 years. So, as I mentioned, the point here being that because we understand so clearly the causal role of HPV, we can intervene in different ways. The traditional way of doing cervical screening, as I'm sure everyone here knows, is cytology or pap smear testing. But to be effective, this has to be done very often in a woman's lifetime. More recently, we've seen the emergence of HPV-based testing, and I'll talk a little more about that in a second, but testing for HPV DNA or RNA, in other words, a molecular test for the presence of the virus itself in cervical or vaginal cells. And of course, we now have the possibility of primary prevention with prophylactic HPV vaccination. While we're talking about models, I just want to take a moment to tell you about some of the methods that we use to predict the effects of these interventions. And really, I've put it here because this is actually, in a way, and it just captures that natural history model I just articulated. And so the fact that the natural history of HPV and cervical cancer has been so well described has greatly facilitated the development of model platforms by our group and by others. So this is just a simplified representation of the type of platform we use. We have a dynamic transmission model of HPV infection and acquisition and indeed vaccination in the community. That leads to a model of the natural history of CIN progressing to invasive cervical cancer. We overlay that with testing, diagnosis and treatment pathways. And we can extrapolate the results from very detailed in-country models to multiple countries or a global level with simplified assumptions. And we can also look at a range of knock-on outcomes, including, for example, the number needed to treat or the number needed to colposcope to prevent a cervical cancer death. We can also look at, of course, costs and effects, harms and benefits, and some of the subsequent sequelae of being tested and treated for cervical disease, including the possibility of adverse pregnancy outcomes. So that's just the type of platform that we use for some of the results I'll show you today. So going to HPV vaccination then, there is a wealth of evidence now, and I'm just going to give you a very rapid tour of the evidence supporting the effectiveness of HPV vaccination. This slide just shows a depiction of the pivotal trial results in 2007 and 2009, I think, for the two first-generation HPV vaccines. So These vaccines both protected against HPV type 16, which causes about roughly 50% of invasive cervical cancers, and also HPV type 18, which causes a further 20% roughly. So together they protected against 70% of cervical cancers in fully immunised women. One of those vaccines is a bivalent vaccine, that's the GSK vaccine, and the other is a quadrivalent, that's the Merck CSL vaccine. So as well as protecting against HPV 16 and 18, it also protects prophylactically against infection with type 6 and 11, which cause the majority of anogenital warts. And in both cases, for both of these vaccines, there was a demonstration of very high efficacy for prophylactic vaccination, so in HPV-naïve females. So the primary endpoint of these trials was around the development of HPV-16 and 18 associated high-grade precancerous lesions, and the efficacy was of the order of 98% or higher in both cases. But it is worth noting that efficacy of vaccination, of course, was much lower if it was delivered to a population which was not exclusively HPV naive, because this is very much a prophylactic vaccine. It isn't. It's arguably much less. Not arguably, in fact, it is much less effective if it's delivered at a population level if women have already been exposed to HPV. And so that means that when we're thinking about catch-up programs, there is a much lower efficacy experienced at a population level when you have that mixed prior exposure to HPV infection. And the other thing, of course, to keep in mind with first-generation vaccines is they only protected against those two types. So they did not protect against the mix of HPV types implicated in the remaining 30% of invasive cervical cancer. The good news, though, was that there was a subsequent this development of next generation vaccines. So this is the this is a depiction of the trial results for the next generation nonavalent Merck vaccine. So that's a 9-type vaccine. So adding in 5 additional types, which we call the high 5, HPV 31, 33, 45, 52 and 58, and added to the original 16 and 18, this in combination protects against 90% of cervical cancers, again in fully immunised women who were immunised before exposure. Furthermore, there was some subsequent good news about the bivalent vaccine, that it actually turned out that it appears to have quite broad spectrum protection as well, because it uses a different adjuvant, and this appears to boost cross protection for at least 3 other types. So these are data from the vaccination and screening programs, in fact, in Scotland, published in BMJ in 2019. And this just shows that compared to unvaccinated women born in 1988, that vaccinated women born in later years had a much lower risk of developing CIN3+. And you can also see, by the way, herd immunity here in these later cohorts, so that the unvaccinated women in cohorts that had been exposed to vaccination as young girls also experienced indirect protection. So obviously good news. So what this meant in effect is that over the last few years, we've seen the emergence of 2 vaccines that appear to have relatively broad spectrum protection. Now, I just want to use my own country, Australia, as a bit of an example for some of the concepts and an example of how this is rolled out in practice. So just to tell you a little bit about the Australian National HPV Vaccination Program. It was actually Australia was the first country in the world to implement a national publicly funded HPV vaccination program from 2007, involving routine vaccination of 12 to 13-year-old girls with a school and GP-based catch-up, which was very wider than I believe in the UK. It went up to age 26 years over the subsequent 2 years. So this was delivered by a combination of primary care and school-based catch-up. The other factor in Australia is that boys were included in the program from 2013. And just as a bit of an aside, and I won't talk a lot about male vaccination or male HPV-related cancers, but as many will know, HPV vaccination in boys has been quite controversial, and its cost effectiveness has not been consistently demonstrated in all settings. It's certainly not recommended at this time in emerging markets or in low and middle income countries, particularly as there's a current issue around vaccine supply. So it is a question of prioritisation, but in Australia it has been implemented. So we have achieved quite high coverage. It's 80% coverage in girls for full dose completion, 76% in boys. These data are a little bit dated now, actually, and we're just awaiting the emergence of updated data. This is 3-dose coverage, which was required up until 2017, but we've now been able to move to a 2-dose schedule from 2018 onwards, and Australia has now switched to using the nonavalent vaccine. It's worth, as another aside, to say that there's a lot of work going on to really demonstrate the efficacy of single-dose vaccination, and this will be a key development in making vaccine delivery more achievable, particularly again in low and middle income country settings. So in Australia, again, because it was the first country to roll out the vaccine, it was also the first country for which vaccine impact was able to be demonstrated. And on the left here, you see the pre-vaccination picture in terms of HPV type 16. So this kind of bolus of infection in younger women, and then most of that clears, and then you just see this persisting infection essentially in women over the age of 30, which is putting them at higher risk of developing CIN3 and then invasive cervical cancer. So you can see observed data in the dotted blue line, and this is modelled. This is a modelled simulation fit to the observed data. And what we did as this vaccine program was rolling out is we used the initial coverage data experienced in the program in a dynamic HPV model just to look at the predicted effects. So I'm just going to run this simulation as we did it at the time. That's 2006, 7, 8, 9 and 10. And so we had basically predicted this incredibly rapid roll-off of HPV-16 and indeed included HPV types infections essentially within the first 5 years of the program. And you can see this kind of flatlining effect that's occurred for HPV-16 infections. And what you can see on the right is that this has been very definitively documented to happen. So these are 2018 data on HPV-16, and you can see more or less a 2% flat prevalence in the Australian female population currently. So that's very exciting. The other thing that I want to mention is a key paper that appeared just in October last year, and this is by Jaeyao Lee at the Karolinska. And really using Sweden register data, she and her colleagues were the first to demonstrate direct protection of vaccination against invasive cervical cancer. So you can see the key results here. After adjusting for all covariates, they showed an incidence rate ratio of about 0.12 among women who'd been vaccinated before the age of 17 years. And about a half in women who'd been vaccinated at an older age, bearing in mind that the population level efficacy of vaccination is not going to be as high the older women get just because of that mixed vaccine exposure. So a very cogent demonstration of direct protection against invasive cervical cancer. Now I just want to move to talk about cervical screening, then I'll come back to talk about how vaccination and screening interact with each other. So again, as many of you will know, there's been organised cytology-based screening programs established in many, many high-income countries for decades. And just a few years ago, we did a bit of a review of the effect of the program in Australia. In Australia, we had a 2-yearly cytology-based program which was established in 1991. It involved screening women from the age of 18 if they were sexually active up to the age of 69. And these graphics just show the results for women in different age groups. So in the 20 years after the establishment of the organised cytology-based screening program, we showed that there were falls in cervical cancer incidence of roughly 50% in women from the age of 25 to 69, and in fact that seemed to be sustained in women over the age of 70, possibly because we actually had quite a bit of opportunistic screening in the age group, and also because there may be a carryover effect for some years after a woman exits the screening program. But it is really notable, a few things here. Firstly, that there was no change at all in the rates in women aged under the age of 25 years from screening over those years. There was no change in adenocarcinoma, a histological type which is normally associated with canal lesions, which are much harder for the cervical smear to access, and for those cells to be sampled adequately. And the other point to make here is that the rates in our program plateaued really essentially after the first decade of the program. So although there was an impressive reduction initially, it really plateaued. And that's probably just due to the limits of a pap smear that requires this really frequent cycle of screening to be effective in women. The fact that it's really difficult to access all rural and regional women, and in our context, Indigenous women and other high-risk groups. And the pap smear was just reaching, I think, the limit of what was doable at a whole of population program level. And we have seen similar effects in other countries. At the same time, there's been an emergence of a wealth of data on using HPV DNA testing. And this slide just shows the results of a relatively recent Cochrane review. There have been many meta-analyses of the sensitivity and specificity of HPV versus cytology-based screening over the years. This is just one of the most recent. And you'll see here, this is a depiction of the absolute sense and spec at a cross-sectional level for HPV testing. This is for the detection of CIN2+. So around about 90% sensitive and 90% specific, compared to the pap smear, which even in a well-controlled high-income country setting is roughly 73% sensitive, but better in terms of specificity. And you can see this playing out in terms of the relative sensitivity and specificity between the two tests. So that's the cross-sectional picture. Longitudinally as well, we I think have been really able to benefit from a wealth of information contained in HPV testing, and in particular this idea that a woman who is HPV negative is at really low risk for a number of years, because it simply takes time for a woman to potentially acquire an infection, for that infection to persist and progress, and to move to invasive cervical cancer. So this is the results of a pooled cohort study by Joachim Dillner and colleagues. And you can see really that this is just the risks of CIN3+ as a surrogate endpoint, the highest grade of pre-cancer or invasive cancer, that's what that means, in women who are screen negative. So for women who are cytology screen negative, you can see that at 3 years, there's about a 0.5% risk of having CIN3+. And you can weigh that up against the risks in HPV negative women, which at 4 to 5 years are still much lower than that, of the order in this particular cohort of 0.2%. The other point to note here is that the green line is actually the results of what we call co-testing, when both tests are done. And you can see that if you have a situation where a woman is negative for both cytology and HPV, you do get improved prediction of low risk of CIN3+ longitudinally, but it's a very incremental benefit from HPV testing alone. Most of that information is contained in the HPV test, and from a cost effectiveness point of view, this is very unlikely to be cost effective, and that has been shown in a number of settings. So just quickly to give you a sense of the trials as well, there have been a number of trials now of HPV screening versus cytology screening. This is one from Canada that reported a couple of years ago by Gina Ogilvie and colleagues, and they randomised 19,000 women, individually randomised to HPV versus cytology. And for women who were screened with HPV, they were tested again and exited at 4 years, whereas women who were screened with cytology were screened at 24 months and then at 48 months. And you can see the results here, but essentially, to cut to the chase, women who are HPV negative at baseline had a significantly lower cumulative incidence of CIN3+ at 4 years compared to cytology negative women, and the risk ratio there in that case was 0.25. And then finally, we've also seen pooled trial data with invasive cancer outcomes, not just CIN3+, but invasive cancer outcomes. And this is from Ronco and colleagues, published actually now 6 or 7 years ago. And this is from 4 European trials, 176,000 women. And you can see both in all randomized women and in women who are screen negative, a much lower risk of invasive cancer in HPV negative women. And they concluded, in fact, that in women with a negative screening test, the rate ratio was around 0.3. And from that, they said that over the long term, the relative protection of HPV versus cytology was roughly of the order of 60 to 70%. The other thing I want to point out before I go on is that it's not just the high negative predictive value that's important for HPV, it also gives us risk predictions if a woman is positive, because there's information contained in the HPV type about what that means for her future risk. And this is actually, this slide shows a very old cohort, in fact, but this picture is played out time and again in the data that we've seen over the last couple of decades. And essentially what we can do is we can start to get to something like a traffic light system where we know that a woman who has HPV 16 or 18 and a couple of other types can be assigned a higher risk. A woman who has another oncogenic HPV type, but not 16 or 18, can be classified as intermediate risk. And again, women who are HPV negative are at much lower risk. And this really is important. It's an important concept for screening. And the other thing I want to point out to foreshadow what I'll talk about next is that what's really useful here is that 16 and 18 are not only the highest risk types, but they're of course the types that were included in first generation vaccines. So this really opened up, I think this picture opened up the possibility of really tailoring risk predictions in screening programs to what was happening in vaccination programs in quite a dynamic way. Finally, I just want to mention that the other big benefit of HPV testing is that it has been shown that we can use HPV to allow a woman to self-collect her own sample. And this holds enormous promise from the point of view of improving access to screening. There are so many cultural and psychosocial and psychosexual barriers to having a pelvic examination. And it's been shown, again, in many different contexts and countries that a woman being able to take her own self-collected sample is really promising from the point of view of improving screening coverage. So these data from Mark Arbon and colleagues are from a meta-analysis. It's just showing the summary ROC curves for HPV self-collected versus clinician-collected samples. And the key point that he showed is there is a loss in performance. This is self-sample versus clinician sample for what's called signal amplified tests, so a subcategory of HPV tests. But if a PCR test is used, then the self-collected sample, which is actually a vaginal sample, really just relying on small amounts of DNA in that environment, not directly sampling from the cervix, actually achieves equivalent sensitivity and specificity. So this is really an important, an incredibly important result, and particularly has facilitated discussions around access to screening in low and middle income countries. Now, just moving on to the vaccine screening interaction, because this has been really the big topic and in a way the big challenge over the last decade or so since vaccine programs rolled out. So vaccination, I think, in many high-income countries either has been or is becoming a direct prompt for changing the screening program. So I showed you a lot of convincing emergent evidence on HPV-based screening, but it's still very hard to turn around to change a national screening program that involves so many different elements and components. And vaccination, though, I think has been a very proximal prompt to this, and certainly it was the driver for change in Australian context. Because I think the key challenge is that given vaccination in a population, you've got a very dynamic unrolling situation from the perspective of the lifetime risks of cervical cancer within your screened population. You don't actually know what those risks are for any one individual woman, because she might have been vaccinated. She may not, unless you have good registry systems, and many countries don't, she may not remember whether she was vaccinated, say as a 12-year-old by the time she's screen age. You may not know which type of vaccine, how many doses she had, or she may have been unvaccinated but still benefit from herd immunity because she was in a cohort that was exposed to vaccination, or even exposed more generally at a population level to herd immunity. So the question really, I think, is how this should be factored into cervical screening decisions, and there's been a huge amount of discussion and debate about this. I think just to mention in Australian context again, because we had this very wide catch up to the age of 26 from the beginning. We had this low age of starting screening. We started screening down at 18. So we had this huge overlap of vaccinated and screened women from the very inception. And obviously that increases over time. So now, 14 years on from the beginning of the vaccination program, basically all women aged 40, around 40 years or younger, have been offered HPV vaccination. So we're really getting to that young and mid-adult population in our screening program have had now significant exposure to vaccination. So all of this prompted, just again using Australia as a quick example, it prompted a major review, which we call Renewal, which was kicked off in 2011, and its aim was to ensure that all women, vaccinated or not, had access to a screening program that's acceptable, effective, efficient, and based on current evidence. And because there was no direct evidence of screening in a vaccinated population, we had lots of direct evidence of HPV-based screening or cytology screening in unvaccinated populations, but we had no direct evidence of screening in a vaccinated population. So really modelling was the only way forward for this review. And this slide depicts the modelling that we did to support the review of the program. We looked at the difference in performance between cytology-based and HPV-based screening in both unvaccinated cohorts and in fully vaccinated cohorts in this case, and essentially showed that you would get a relative benefit of between 24 and 36% in cervical cancer incidence and mortality over the long term from introducing HPV-based screening in both cases. And because you're also screening at a longer interval, you save costs. So it was a win-win situation. The other thing that we did is we've set up a very large-scale trial of the kind that I just showed you. The HPV-Focal trial in Canada was one example that we used. But the trial in Australia is different because it is being done in a population that has significant exposure to vaccination. So this is an individually randomised trial of HPV screening versus cytology-based screening. We're stratifying by whether or not a woman is in a cohort that was offered vaccination, and we have 76,000 women on study. And so we're very much looking forward to being able to analyse some of the initial data from the main trial over the next couple of years. We have published, and this shows the publication from our pilot study, which is around 5,000 women. And even in the pilot, we were able to show on the baseline screening round a significantly increased detection of high-grade precancerous cervical lesions compared to cytology for HPV-screened women. And for the first time, we showed this was also true in a population that had been exposed to high levels of vaccine uptake. So all of this together, the trial that I showed you, which is acting as a sentinel experience and helping to monitor the safety of our program, and the modelling supported this major program change where we changed in 2017 from 2 yearly cytology starting at age 18, 26 tests in a lifetime for a woman who does all the screening involved, to 5-yearly HPV screening starting at age 25 because of the evidence showing that screening was not effective in younger women, and far fewer tests in a lifetime. And this is just a depiction of the cervical screening pathway that we use in Australia. It is a bit different to the pathway used, at least initially, in the UK. And the key point being here, we've implemented as a real strategy this traffic light system that I alluded to earlier. So essentially a woman presents for screening, has an HPV test with what we call partial genotyping, meaning that we distinguish between whether she has HPV-16 versus other HPV infection. If she's HPV negative, she just goes to 5-yearly screening, that's green. If she's HPV-16 or 18 positive, she goes essentially directly to colposcopy with a pap smear taken on the way to inform colposcopy, so that's to diagnostic testing. And if she has another oncogenic type, that intermediate risk group, she has a reflex cytology, liquid-based cytology, and based on the results of the cytology, that determines what happens next. So it's very much this idea of risk stratification in action. And I guess key to all of this is this idea that remembering that we had this bolus of 16 and 18 infection pre-vaccination, but post-vaccination, we now have a flatlining of HPV 16 and 18 infection. So we really have quite contained numbers going through this high-risk pathway in a post-vaccination context. Just incidentally, I will say that one of the things that we have been managing in our program is that we still have a lot of infections in young women for other HPV types, and that's generated various fairly large numbers of women's going into these surveillance pathways from that pathway. So we are, in fact, in the process of revising the program to deal with that. So putting this all together then, one of the things that we wanted to do is predict what this meant for the way forward. So I've told you about Australia. We had a long-term cytology-based program from 1991. We had vaccination introduced in 2007. We had male vaccination introduced in 2013, which actually does protect women because there's additional herd immunity back to women. We had the switch to the next generation vaccine, which happened in 2018. We had the switch to primary HPV screening in 2017. So there was essentially 5 different steps. And we put this all together to actually predict rates of invasive cervical cancer. And you can see this is our prediction, which we published in, it came out electronically in 2018. It was the first elimination analysis. And we predicted essentially, you can see this blip from the introduction of the HPV-based program with that more sensitive test coming in, picking up more prevalent cancers, a rapid fall because of the HPV testing, and then the longer term effects of HPV vaccination kicking in. And we predicted essentially that within a very few years, Australia would drop below a rate of 6 per 100,000 women per annum, which is considered the definition of a rare cancer. And that we had put this notional threshold for elimination forward, whereby cervical cancer could be considered to be controlled. And we had put forward at that point the idea that 4 cases per 100,000 women would be a useful threshold. And we had put a timing on that of 2028 for Australia if it stayed on track, with a bit of a range there depending on the various assumptions. Incidentally, we also looked at a scenario where those cohorts, those young cohorts that are, as 12-year-olds are now getting next generation vaccines, had absolutely no cervical screening at all. In other words, that we start to withdraw cervical screening from those that have the next generation vaccine over time. And you can see that that actually keeps us well under the elimination threshold, albeit not achieving rates quite as low as if we keep intensively screening. So this was the first elimination analysis. There have been a number since, and I just want to highlight one of those that we did with collaborators in the US. This is a projection of elimination timing in the US context. This is the results of 2 models. This is our collaborators at Harvard and our own model, Policy 1 Cervix. And you can see fairly similar results between the 2 models, taking into account vaccination and screening exposures and protocols in the US. We concluded that the US is somewhat behind Australia, but is still on track to eliminate cervical cancer as a public health problem in the next 2 to 3 decades. But the time to elimination could be expedited by a decade or more with the achievement of higher screening coverage, and that would be the key factor. Remembering again that vaccination is a longer term game changer, but because you're delivering it to young people and its effects really manifest over decades, it's really not the lever that you pull if you want to increase, if you want to get to elimination more quickly. So I've been talking about high income countries, and now I'm going to move to low and middle income countries and talk about what the prospects and timeline for elimination might be at the global level. So what was incredibly exciting to those of us in this field is that in 2018, the WHO Director General, Dr. Tedros, called for all countries to take action to help end the suffering caused by cervical cancer. And so essentially what this did is it kicked off a major process whereby WHO activated a process by which they worked with stakeholders to put together a draft strategic plan to achieve elimination, and indeed to define elimination as well. And in doing that, we were able to work with them because we had been working with Freddie Bray and his group at IARC to do the first global projections of the burden of cervical cancer under different scenarios for vaccination and screening. And I actually want to call out Kate Sims, who's a wonderful research fellow in my team, and Julia Steinberg, who were both involved really closely in this work. This was a really long-term project, and what we did is we really looked, we modelled globally. We looked at the current status quo for the projected global burden of cervical cancer, and then we looked at various scenarios. So here's the situation. We were using data for vaccine exposure to 2014 when we did this work. And you can see at that time, there was pretty good exposure in high income countries. About a third of girls in the target population had been vaccinated, but less than 3% had been vaccinated in LMIC. And so based on that, we had concluded that up until that point, 1 million cases had been averted in the 50 years from 2020, and all of the numbers on the right are 50-year snapshot numbers for the cumulative burden averted. So we then modelled what would happen if you actually had a very high vaccine uptake with first generation vaccines. So this is 80 to 100% vaccination uptake with quadrivalent or a quadrivalent vaccine, and you can see you get about 5 to 6 million averted in that 50 years. But that, again, because of this long-term nature of vaccine impact, that unfortunately things get worse before they get better in terms of burden of disease. And on the y-axis here is the annual cancer cases in thousands, so you can see that going up quite considerably before turning around with in a 2 to 3 decades time. If we use broad spectrum vaccines, you can see that you get results more like 6 to 8 million averted, which again is very encouraging, but unfortunately you really have this longer term effect. And I think the key insight here that we were trying to get to and demonstrate cogently was that you needed to do something with the older cohorts who've already been exposed to to HPV and who won't benefit from vaccination. And really at the moment what that intervention is cervical screening. So we then added in twice lifetime, a fairly minimal screening of twice lifetime screening at 70% coverage globally, and you can see you vastly increase the number of cases averted over the next 50 years to about 12.5 to 13.4 million. So this was really useful in thinking about elimination, and we were working with our WHO colleagues with these results and looking at how they played out in different income categories of countries. Through the process of the next couple of years, WHO and its stakeholders used some of the modelling results that were done, not just by us, but by a consortium that was then established, to put in place 3 pillars and 3 sets of targets for elimination, and they're depicted here. So WHO's final strategic plan recommends these 3 targets. So the 3 pillars are vaccination, that 90% of girls are fully vaccinated by age 15. 70% of women are HPV screened with a high precision test, not with cytology, at around age 35 and 45. And then 90% of women that require treatment who are identified with precancer or cervical cancer are treated. Now, just at the bottom here, we've got the status quo as at 2019 in LMIC. So actually there was good progress in around 2019. There were lots of efforts to actually increase particularly vaccination in LMIC, but still we had less than 20% of low-income countries and less than 30% of low and middle income countries had introduced HPV into their national immunisation programs. It's difficult to know, in fact, how many women in LMIC access screening, but the estimate has been from WHO that less than 20% of women have been screened in those settings. And really sadly, that less than 30% of women, even with invasive cervical cancer in those settings, are actually able to access appropriate treatment, including not only basic surgery and radiotherapy, but even if they require palliative care. So to put some impact assessment on this, we came together with 2 other modelling groups, the Harvard group that I mentioned before, and a group from University of Laval, and formed with WHO, the WHO Cervical Cancer Elimination Modelling Consortium, to really kind of back up the estimates in the strategic plan. I'm just going to show you some of our results quite briefly. These are the results for cervical cancer incidence, and what we did is we focused on the 78 poorest countries in the world, so 78 LMIC. You can see the starting point in 2020. Cervical cancer incidence, if it's over 15 per 100,000 women years, is in this red colour. Light blue is 10 to 15. Mid blue is 4 to 10, and eliminated is navy blue. And you can see how things play out if you scale up vaccination and screening. And essentially, we were able to show that even the poorest countries would be able to eliminate cervical cancer by the end of the century. One of the key aspects of this, though, was the question about the lives that you can save along the way. And I think we've been at pains to try and explain that it's not just about elimination as an end goal. That's designed as a motivating factor for countries and for governments. It's about the lives that you can save along the way. And so this is the implications here for cervical cancer mortality. So this is across the 78 LMIC, and you can see this is, sorry, my screen is advancing itself, but you can see here that the rate is across that LMIC on average is around 13 per 100,000 women of mortality at this point in time. And this is how it would play out for different scenarios. So we have the blue, girls only vaccination. Sorry, girls only vaccination. Green is vaccination with once lifetime screening and cancer treatment. The purple is the elimination strategy, and the other scenarios here are different ways of delivering vaccination with multi-age catch-ups or vaccination of girls and boys. But I think the most important thing to look at here is the results for purple, the elimination strategy. So 90% girls vaccinated, 70% get twice lifetime screening for women, and 90% of women that require cancer treatment actually get it. And the key point here being that we were able to show a 1/3 reduction in mortality rates by 2030 if this can be achieved, a 92% reduction by 2070, and a 99% reduction over the course of the century. And this would obviously, from a proximal point of view, contribute to the Sustainable Development Goals around a 1/3 reduction in mortality from NCDs by 2030. So very exciting. We all, of course, know that even pre-pandemic, this was a stretch goal, but again, it's designed to be motivating for countries. And similarly, that would save lives. So this is an implication, this is an estimate of the number of lives saved even by 2030, and mostly because of the expanded access to cancer treatment services. There would be 300,000 lives saved, 14.6 million over the next 50 years, and 62 million plus over the course of the century. We were also able to show that for most countries, this would not only be impactful, but it would actually also be cost effective. And we are continuing to do quite a bit of work for countries on the investment case. So all of this supported WHO's cervical cancer formal strategy launch, which actually happened on 17th of November last year as a result of the work over the last few years. And again, we hope that countries will be able to take this forward. One of the things that we've been working on is trying to tease out the implications at a country level. And this is just a small project we've been doing with UNFPA, where we're developing policy briefs where we can give countries themselves their own numbers so that they can, I guess, be incentivized about the numbers of lives that they can save if they can scale up to elimination. So very quickly, COVID, of course, is having an impact. It's had an impact in terms of disruptions to vaccination programs, delays to initiation of new programs, disruptions to trials of one-dose vaccines, and the potential for complex impacts of COVID-19 on vaccine hesitancy. From a screening point of view, there's disruptions to established screening programs in high-income countries, of course, including in the UK. Supply disruptions impacting our ability to scale up HPV testing, and disruption of cancer treatment services. And so our current work is with IARC and what's been set up and what we're calling the COVID-19 and Cancer Global Modelling Consortium is really trying to characterise the impact of these disruptions and to help countries design appropriate recovery strategies. And just to make the point as well that every year that we delay elimination, this is really a serious cost, because cervical cancer was estimated to take the lives of 342,000 women in 2020, and you can do the numbers and compare that to the number of lives lost from COVID, and it is a significant proportion. So it is extraordinarily important that the global community reaffirms, I think, our commitment to elimination, and the logistical and economic challenges are going to be immense. There's no denying it, but I think the important thing will be to keep our eye jointly on the 2030 goals, and that the positive benefits of elimination need to remain firmly in our sights. So I hope I've given you a bit of a flavour. I've probably gone a bit over time of the road to cervical cancer elimination. How long will it take? Well, it will take less than a decade potentially. In a country like Australia, it will take several decades, maybe even until the end of the century in some of the highest burden of disease countries. But it's the lives that we save along the way that's the important thing. So thank you very much for your attention. I'll hand back to Valerie.
Well, thanks, Karen. That was really fantastic. And you know, in epidemiology, you don't hear these success stories very often, and this is wonderful, and it is a success story, even if for many people it's through the rest of the decade. We've got a question here, and I'll try and simplify it a bit, but about the vaccine, like, is this expensive? And I wonder if you can even just tell us some idea what the costs are and what the commitment is to provide vaccines around the world. How does that work? Just the logistics and the real costs.
Yeah, it's a huge issue. I mean, there's issues around costs, and I will mention there's huge issues at the moment around vaccine supply as well. I mean, in high-income countries, if you look at a country like the US, it's several $100s traditionally per dose. I mean, it's extraordinarily expensive per dose. But that's the US. I mean, I think for national immunisation programs around the world, even in high-income countries, we don't understand, a lot of it's not public domain because this is a negotiated pricing with suppliers and often potentially with more than one supplier in that mix. But we think that the pricing in a lot of European countries is probably more around the range of 10 to 15 to 20 euros per dose. And that's certainly the pricing that's available through some of the middle income country funds. For low and middle income countries, the main mechanism to make vaccine accessible from a pricing perspective is the Gavi Alliance, and Gavi pricing is less than $5 per dose. But the other key aspect that is really important here is getting one-dose vaccination over the line. So there are a number of trials ongoing now, and that will help, of course, not only from a delivery point of view, but from a pricing point of view, and to help solve the manufacturing and pipeline problems that we're now experiencing as well.
That's really, I mean, the one dose sounds really interesting and very worthwhile. When do you think the results will be of the one dose trials?
Well, they have been interrupted, so I guess we're not totally sure at the moment. There was one of the major trials is an NCI trial in Costa Rica that had a 4-year follow-up. I think they were a couple of years in. So, you know, I mean, there's a lot of emergent evidence observationally. It's pretty, I think it's pretty convincing, actually, even from the observational data. So, you know, from programs like Australia, we can see protection against high-grade lesions, even from one-dose vaccination observationally. So I think that, you know, I think there'll be probably quite a lot of discussion and debate about what it will take to get it over the line in the context of the emerging evidence. And, you know, but at this point in time, we're certainly all waiting for the trials. Mm-hmm.
Okay. Now, there's another question asking, why doesn't the vaccine work in people who are already exposed? Although I think you showed that it does work, it's just not as good. Is that right?
Yeah, no, that's a great question. I mean, I'm a bit limited at not being an immunologist, but it doesn't work well if you're exposed. I mean, I think it's type specific, so you can be exposed to one type and still get protection against another type. There's a bit of debate going on about whether you know, what the level of efficacy is if you have been infected with a type but you've cleared that type and you're seropositive but DNA negative. I think the evidence there is still even now less clear, but it is truly a prophylactic vaccine. I mean, there's a whole different area of development for what's called therapeutic vaccines, or, you know, immunological therapy, which are really aiming to increase clearance of the virus, etc. But the current vaccines are, I think, truly prophylactic.
Okay, we have 1 minute left. I'm going to ask a question that you can't possibly answer in a minute, because it's about the word elimination. Now, you know that there's been a lot of talk about that being it's not really eradication, and it's just a word that it sounds very good. We've eliminated it, although it's still 4 cases per 100,000 per year. And so, can you just talk us through a little bit in the 1 minute about what the word elimination and the definition, and whether this is a good thing to use or not, a good term to use or not?
Well, it's certainly controversial. I mean, I think you know, the feelings run very strong on this. I think it has its uses. You know, I think we have to see it as a tool for advocacy, and I guess I've just seen, having worked in cervical cancer, as you said, Valerie, for 20 years or even more, how this has been transformative from a resourcing point of view. Just this concept of elimination for funders and, you know, for everyone. I mean, it's even in COVID times, there is a lot of resourcing coming into the field, and I think in a way WHO have been very clever with this, and I know it's not the only disease that they're talking about elimination on. I think we have to be very careful. It's not viral eradication. It's definitely not that. It's a notional threshold that's used to rally stakeholders, and I think so far it's actually been pretty effective. So I guess I'm all for the results. I'm not so much of a purist.
Okay. Well, look, thanks, Karen. That was really fantastic, and I think for many of us who aren't following this field so closely, it's really provided a background over many years and a projection much into the future. So thanks very much. I think it was very, very interesting, and I think many will really will go away much educated from this. Thank you.